Thanks everyone for joining. Um, we're delighted to have our annual Arthur Newman lecture in rheumatology. And since I'm one of the oldest people in the room, I actually knew Arthur. And so I just want to share a little bit about him with all of you. Arthur was a force to be reckoned with and was really a trailblazer. He had a long history in pediatrics. And interestingly, he was initially a peds hemonc doc. And so he used a lot of things like methotrexate and those types of things. So he realized that those drugs would probably be helpful and actually went off to work with one of the first rheumatologists in the country. He was probably the second or the third or something like that. He got that training and then came back and used some of those drugs that he was familiar with as a peds hemonc person to treat children with rheumatologic diseases. The interesting thing about Art was he was so dedicated to his patients. There again, he started at a time where there was not much rheumatology. There weren't many adult rheumatologists either. And so he cared for his patients throughout their life. Even though he was only trained in pediatrics, he would follow his patients, something he learned from all of his CF colleagues until they grew older. Art was here until he retired. He passed away about 10 years. But again, he really made an impression not only on those he trained, but really on the field of rheumatology as well. Dr. Fadke, if you'd like to introduce our guest.
Turn on the laser pointer for him.
Good morning, everyone. Thank you for coming. It's my pleasure to introduce the speaker for today. Dr. Alexey Gram is a professor of pediatrics and the research director in the Division of Rheumatology at Cincinnati Children's Hospital. He's a clinician scientist who's interested in systemic juvenile idiopathic arthritis. And currently, his research is focused on identifying the risk factors and the new therapeutic targets in MAS, or macrophage activation syndrome. His transnational studies have identified interferon gamma as a therapeutic target in patients suffering from MAS. And this discovery provided the rationale for the new clinical trial that is currently underway, where he serves as the PI for North America. His research is funded by the National Institute of Health and the Sjia Foundation, as well as research grants from Sobi, Novartis, and Novimmune. Thank you, Dr. Gram, for being here.
Well, thank you very much for the invitation and for the opportunity to share our experience with the seemingly new complication of systemic juvenile idiopathic arthritis. And I'm referring to this very bizarre parenchymal lung disease. It's a very controversial topic. And please interrupt me if you have questions or if you disagree with some of my statements. I will start with a brief clinical description of this phenomenon. I will discuss then some of the proposed hypotheses about the nature of this lung complication. And then if we have time left, I will discuss some of the approaches to the screening and management of this complication that we use in Cincinnati. These are my disclosures. I received consulting fee from Novartis and Sobi, and certainly some of the discussion is relevant to several of their products. Now, I would like to start with a brief historic perspective on the treatment of juvenile idiopathic arthritis in general. Some of us probably remember that the introduction of methotrexate in the late 80s and then anti-TNF inhibiting agents and the abatacept in the late 90s led to a dramatic improvement in the outcomes for patients with non-systemic juvenile idiopathic arthritis. However, the same therapeutic modalities did very little for patients with the systemic form of juvenile idiopathic arthritis. What did make a huge difference for those patients was the introduction of IL-1 and IL-6 inhibiting biologics. And those drugs were finally approved by the FDA in 2012. As a result, these dreadful complications of systemic juvenile idiopathic arthritis are now becoming exceedingly rare. I remember as a fellow seeing patients with systemic juvenile idiopathic arthritis, and I would tell you that about 50% of them would develop very severe destructive changes in their joints with ankylosing in the spine by the end of the second year of the disease. About 1/3 of those patients would require a total hip replacement surgery while they were in the pediatric age. It was a terrible disease. Now, I don't know, as fellows, even probably, do you have this kind of patients? We don't in Cincinnati. So the introduction of this IL-1 and IL-6 inhibiting biologics dramatically changed the outcome of typical features of systemic juvenile idiopathic arthritis. However, despite this, the rates of macrophage activation syndrome have not changed, and we still continue to see this complication perhaps even a bit more often than before. But most disturbingly, we started seeing an increasing number of patients with this seemingly new chronic parenchymal lung disease. And certainly the emergence of this complication did coincide with the introduction of these biologics, raising a concern that perhaps there may be a connection. From the very beginning, I would like to stress the point that this particular complication is very specific to systemic juvenile idiopathic arthritis, and this exact phenotype has not been reported in other rheumatic diseases treated with the same biologics. And another important point to consider is there are striking geographic differences in the distribution of this disease that actually do not correlate with the patterns of utilization of the biologics. So we'll get to that point in a few minutes. Now, if we go back, the chronic parenchymal lung disease in systemic juvenile idiopathic arthritis, at least when I was a fellow, was exceptionally rare. And I'm providing this quote from a review article that was published by a very good pediatric rheumatologist, Balu Athreya, in 1980. And in this specific article, he made these statements: patients with systemic onset JRA and pleural disease recover fully. In children with parenchymal disease, residual abnormalities include radiographic evidence of interstitial fibrosis and minimal abnormalities of pulmonary function. I would like to stress this point: minimal abnormalities in pulmonary function. This is strikingly different from what Yuki Kimura described in her paper published in 2013. Using the CARA cohort of patients with systemic JRA, she identified 25 patients with chronic parenchymal lung disease. The majority of these patients had pulmonary artery hypertension, as well as features of pulmonary proteinosis. And most disturbingly, 17 of these 25 patients died, suggesting that the mortality with this complication may be as high as 68%. And most of these patients, in fact, were diagnosed with this particular lung complication after the introduction of the IL-6 and IL-1 inhibiting biologics. And if you look at this particular table, patients with this lung complication, the exposure to this biologic in this cohort was actually much higher compared to the cohort of patients with SJIA in general. So the burning question is, do IL-1 and IL-6 inhibiting biologics contribute to the development of this particular lung complication? Now, I would like to move on and just briefly describe the Cincinnati experience. I believe my very, very first patient with this phenotype showed up in our clinic in 2010. And then probably starting somewhere in 2013, 2014, when we started a massive increase in the numbers, seeing a massive numbers of new patients with this complication. The phenotype is actually very interesting. First of all, there is a striking dissociation between relatively mild initial clinical features of this complication and the severity of the findings on high-resolution chest CT. Typically, the first clinical sign of this complication is subtle tachypnea with activities and very impressive clubbing. And the picture I'm showing here is what I would like to stress is that it's certainly impressive clubbing, But there is a very impressive erythema, periorangular erythema, that actually is very reminiscent to what you might see in dermatomyositis, and it's very painful. When these patients show up in our clinic, typically they show up with huge nails because they don't let their parents clip their nails because it's so sensitive, so painful. So these are sort of the very first clinical signs of this complication. And then when we proceed with high resolution chest CT imaging, we discover massive changes there. At the early stages, probably one of the earliest findings in this phenotype is pleural thickening, shown here with some tree and bud passages. And again, this is a relatively early and mild case. As disease progresses, we started seeing more of those areas of pleural thickening. We also start seeing a little bit of intralobular septal thickening. And then at the later stages of the disease, we start seeing quite a bit of ground glass passages as well as areas of frank consolidation. And in our initial cohort of patients that we reported in 2019, 9 of the 19 patients examined, in fact, had this severe phenotype. And again, even in the presence of these impressive changes in high-resolution chest CT, the clinical presentation was still very subtle, a bit of tachypnea and clubbing, really not much more at the beginning. And then that the disease progresses, many of those patients do develop need for oxygen supplementation. Now, the histopathology of these lesions is also very perplexing. First of all, I would like to draw your attention to this figure at the bottom left. So this is a gross appearance of the lung tissue from a patient with this complication. And as you can see, the involvement is very patchy. So clearly there are areas that look grossly abnormal, but there are also large areas of the lungs that look perfectly normal. And I believe that's a reason the initial clinical findings in these patients are so subtle, because there are still large areas of the lungs that are perfectly healthy. If you look at this tissue at a low level of magnification, you see again areas of relatively healthy looking lungs. And then you see areas of pretty heavy infiltration. And if you look at those areas at the higher levels of magnification, a couple of interesting things. First of all, you see that the alveolar space is actually filled with this proteinaceous material, as well as foamy activated macrophages. And there are also many cholesterol clefts there. And this is certainly very, very similar to what the pulmonologists usually describe as pulmonary alveolar proteinosis. Another feature is this sort of heavy interstitial expansion by lymphoplasmacytic infiltrate that includes both T cells and B cells, predominantly T cells. And if you look at the composition of the T cell infiltrate, we typically see both CD4 and CD8 cells equally present there. Another interesting feature is, remember I mentioned that if you go back to the imaging findings, right, you see this subpleural consolidation, right? And that area, those areas over time start looking more and more fibrotic. And in this example, we are looking actually at the polychrome stain that identifies fibrotic tissue. So these patients over time do develop fibrosis. And again, remember I mentioned that paper from Yuki Kimura. Most of her patients had significant pulmonary hypertension. And we certainly do see quite a bit of vasculopathy in the biopsies of these patients. And in this example, we are looking at the pulmonary artery, and you can tell that it's looking really abnormal. Now, as a group, these patients tend to present with the first sign of systemic juvenile idiopathic arthritis very early in life, usually before their second birthday. They typically have prominent systemic features and less arthritis, if any. Many of these patients, the majority of these patients, have recurrent episodes of macrophage activation syndrome, and about 30–40% of these patients have a history of a bizarre anaphylaxis-like reaction to biologics, mainly tocilizumab. And it's not a true anaphylaxis. Really, sort of, I still don't understand the nature of this reaction. Some kind of it looks almost like a panic attack. They drop blood pressure, they start hyperventilating, but they don't develop those sort of typical rashes that we see in a classic anaphylactic reaction. However, over time, most of these patients actually do develop some kind of a pruritic maculopapular rash, often associated with peripheral eosinophilia. And then another major risk factor that I will discuss in a moment is a very, very strong association with the HLA-DRB1 allele. Another interesting feature is that this patient, as a group, tend to have extremely high levels of total IL-18. And, it's an interesting pro-inflammatory cytokine that we will again discuss in a moment. When we see the levels of this cytokine exceeding 100,000 picograms per ml at disease onset, we very much worry about the future development of this lung complication. And based on our estimate in Cincinnati, the prevalence of this complication in systemic JIA currently is somewhere between 5 and 7%. Now, I would like to return back to this histopathological description of the histopathology of lung lesions. So remember, I mentioned that the fact that the air spaces, alveoli space, are filled with this lipoproteinaceous material and foamy macrophages. And again, this is very similar to what we typically see in pulmonary alveolar proteinosis, which is a condition that is caused by impaired ability of alveolar macrophages to recycle, to catabolize old surfactant. So in primary alveolar proteinosis, the impaired ability of alveolar macrophages to catabolize surfactant has been linked to defective GM-CSF signaling, which could happen either secondary to mutations affecting either the receptors or some molecules in the signaling pathway itself, or another typical scenario, some healthy individuals actually may develop neutralizing autoantibodies against GM-CSF, and they would develop this clinical phenotype. Now, in normal physiologic conditions, the population of alveolar macrophages, typically they kind of phagocytose the old surfactant, and then those little phagosomes filled with surfactant fuse with a phagosome, with a lysosome, I'm sorry, and that leads to a quick and complete degradation of the old surfactant. In the absence of appropriate GM-CSF signaling, these macrophages still phagocytose the old surfactant. You start seeing those little granules, phagosomes filled with surfactant in their cytoplasm, but the fusion between the phagosomes and the lysosomes does not occur. And as a result, two things happen. First of all, we start seeing accumulation of these granules in the macrophages, and they acquire that sort of very peculiar foamy appearance. But more importantly, since surfactant is not recycled anymore, now alveoli are being filled with this sort of old surfactant, this lipoproteinaceous material that certainly profoundly affects the gas exchange in the lungs and eventually leads to hypoxia. This is actually an electron micrograph from my very first patient with systemic JIA and this lung complication. And again, we're looking at alveolar macrophage, and you see that it's sort of filled with those so-called lamellar bodies, which in fact are those little phagosomes filled with unrecycled surfactant. So this is very, very similar to what could be seen in pulmonary alveolar proteinosis. So what's causing these features? So because of the similarities, we immediately looked at genetics. We were looking for mutations in the genes associated with primary HLH, could not find anything. We looked for the presence of autoantibodies neutralizing GM-CSF in these patients. Again, none of the patients had them. And then what we did, we took monocytes from patients with this lung disease, and we stimulated them with GM-CSF in vitro, and basically showed that the signaling, the GM-CSF signaling, is absolutely intact. So it's not an intrinsic issue with the macrophages. We believe that something must be coming from the outside of the macrophages that change their behavior. So the question is what? Now, I would like to go back again to the histopathology and show you some other important differences between primary PAP and what we see in our patients. First of all, remember I mentioned to you this massive interstitial expansion with mononuclear cell infiltrate, and it's a very, very impressive inflammatory reaction that actually leads to tissue damage and massive alveolar remodeling. If you look at this particular figure, you probably would not even recognize that it's a lung tissue, right? So the massive damage and then remodeling with some fibrosis, which is actually not typical of primary HLH, primarily PAP. If you look at sort of typical histopathology, at least at the early stages of primary PAP, you would see certainly accumulation of the proteinaceous material in the alveolar space. But if you look at the interstitial space, it actually is in a pretty good shape. It takes many, many, many years for those patients to develop more changes there. So there are differences. And the question is whether in fact, that external influence on the macrophages, alveolar macrophages, is coming from this inflammatory infiltrate in the interstitium. So at some point, we also looked at the cytokine profiles in bronchoalveolar lavage fluid from our patients versus primary PAP, and we actually picked up quite a few differences. First of all, we did pick up IL-18 in the BAL in essentially all of our patients, which was not the case in PAP. And also we picked up evidence of the increased levels of interferon gamma-driven chemokines CXCL9 and CXCL10. And these two are now widely used as a sort of a biomarker of increased interferon gamma activity. So based on that, we believe that somehow the IL-18 interferon gamma axis is involved in the development of this complication. IL-18 was initially described as actually interferon-inducing factor. It's known for its ability to stimulate T cells and NK cells to produce interferon gamma. And interestingly, when we looked again at with the gene expression profiling in lung tissues from our patients, we actually picked up a very strong interferon-induced signature, as well as evidence of T cell activation. And typically, when our pulmonary colleagues from a biopsy, they get an affected tissue and a healthy tissue, relatively healthy looking tissue. And we picked up the same signature in a relatively healthy tissue, suggesting that in fact the activation of the interferon gamma induced pathway occurs before the inflammation becomes clinically apparent. And when we looked at the activation of interferon gamma induced pathways at a single cell RNA-seq level in the lungs, we actually saw that pretty much all these cells in the lungs show evidence of stimulation with interferon gamma. The importance of this IL-18 and interferon gamma activity in this patient population actually was noted by other groups as well. This particular paper is coming from the National Institute of Health, from Rafaela Golbach-Mansky. At some point, she was exploring the behavior of the interferon-induced signature in various autoinflammatory diseases. And as you can see, there are lots of autoinflammatory conditions, including various interferonopathies. And as a group, there is this cohort of patients that she actually described as IL-18 PAP mass. So she even refused to call those patients systemic juvenile idiopathic arthritis. That's sort of the name she came up with for this particular cohort. And again, if you look at the phenotypic characteristic of this patient group, they are exactly what I'm talking about here. It's exactly this group of patients. And again, we're picking up a very, very strong interferon-induced signature, as well as super high levels of IL-18. And if you look at these levels of IL-18, they are comparable to the levels seen in patients with genetic IL-18 driven inflammatories, again, suggesting that this particular axis is probably relevant. Another interesting clue to the nature of this disease comes from the fact that, in fact, if you look at the proportion of patients with Down syndrome in this cohort, is actually strikingly high. It was 10% in the original paper that was published by the group at Stanford, by Vivian Saper and her colleagues. And in our recent cohort, if actually look, it was 15%. So it's a very strong association. If you look, we looked actually at the prevalence of trisomy 21 in the CARA cohort of patients with systemic JI, and it's less than 1%. So clearly we have a very strong association with Down syndrome. So why? So the reasons are not clear, but in fact, if you look at the literature on Down syndrome, so recently more and more people view it actually as a mild interferonopathy. So in other words, in these patients, we see constitutive upregulation of interferon gamma activity. And the reason for that, perhaps, so remember, all the cells that typically respond to interferon gamma, they would express interferon gamma on their receptors on their surface. And pretty much all the receptors for all the interferons are on chromosome 21. So the current understanding of this, or the nature of this interferonopathy in Down syndrome is that because of the gene dosage effect, so all patients with Down syndrome would have more interferon gamma receptors on the surface of the immune cells, so they would develop an exaggerated response to interferon gamma. And we're wondering whether, in fact, that's the reason for the association between this lung complication and Down syndrome. So clearly, we believe that this axis is critical, is very important, plays a very important role in the lung disease. And we think that also this observation may explain the strong association between this lung complication and macrophage activation syndrome, because again, the same axis now is emerging as the critical axis in MAS. In fact, we have lots of therapeutic interventions right now for MAS that target specifically this axis. So what we think might be happening is that we have these episodes of MAS. MAS is viewed as a cytokine storm associated with increased production of various cytokines, including IL-18 and interferon gamma. They activate the resident immune cells in the lungs. They kind of drive this Th1-driven immune response in the lung tissue, and the strong Th1 response would deviate the polarization of alveolar macrophages driven by GM-CSF typically from that pathway that would lead to this phenotype that would allow these macrophages to catabolize surfactant. So some support for this hypothesis is coming from some interesting animal studies performed in Japan. There is this group in Japan that is interested in various aspects of Th1 biology, and they actually developed mice that overexpress Tbat in T cells. And Tbat is a transcriptional factor that actually drives Th1 polarization. So that leads to increased production of interferon gamma. And interestingly, these mice develop two things. They develop pulmonary alveolar proteinosis as well as hemophagocytosis in the bone marrow. So based on that, we believe that sort of this pathway is probably very important in the disease, and that pathway may deviate the behavior of macrophages, and they lose the ability to catabolize surfactant. So that's not the only explanation, obviously. The group in Stanford immediately noticed that the strong association between this lung disease and the presence of sort of very interesting pruritic maculopapular rash, often associated with peripheral eosinophilia. And in fact, Vivian Saper, she is an allergist by training, I believe. She's not even a pediatric rheumatologist. And she felt that certainly that clinical pattern was awfully suggestive of some kind of a drug reaction. So what they did in their initial publication that showed up in Annals of Rheumatic Diseases in 2019, in that particular paper, they described a convenience cohort of 36 patients with this systemic GI and this specific lung disease. And she applied the diagnostic criteria for drug reaction with eosinophilia and systemic symptoms, diagnostic criteria for DRESS. And as you can see on this slide, 13 of the 36 patients actually did meet the criteria for DRESS. And that basically, that observation provided a basis for the concern that in fact what we may be dealing here with actually is DRESS induced by those new IL-1 and IL-6 inhibiting biologics. So to explore that further, so we have lots of allergists here, so correct me if I'm wrong. DRESS typically has very, very strong associations with class 1, HLA class 1 molecules, correct? And so based on that, you explore this phenomenon further. Vivian and her colleagues, they again created a different cohort of patients that included subjects with SGIA collected as probable drug reaction based on this pruritic rash and eosinophilia, as well as a cohort of patients who did not exhibit those features. Then they kind of applied the DRESS criteria to both cohorts. And at the end, they kind of identified 66 DRESS cases and 65 control cases that did not exhibit any features of DRESS. And then they proceeded with HLA typing again, knowing that there is a strong association between DRESS and HLA class 1 molecules. They wanted to see whether they would pick up something similar in this patient population. And what they did actually, they did pick up a very strong HLA association, but it was not class 1, it was class 2. It was a very strong association with HLA-DIB 11501 allele. And tell me, you have occasionally you do see class 2 association in DRESS as well, right? But it's typically, my understanding is typically class 1. But anyway, the association is actually striking. And overall, I would say probably this particular allele is present in the general population, is present in about 27% of healthy individuals. In this cohort of patients, it's at least 80%, not more. Sort of the other thing is that when they looked at the cohort of the patients in this particular publication, those who did score as DRESS, 43 of them, or 65% actually did have this lung disease, and they did not see the lung disease in patients without the evidence of that DRESS-like reaction. So that's how they came up with this idea that, in fact, the lung disease, in fact, could be driven by DRESS reaction to this new biologics. There are lots of questions about this idea. First of all, again, correct me if I'm wrong, my understanding that the diagnostic criteria for DRESS were developed using actually a very large cohort of patients with predominantly non-inflammatory conditions. Most of those patients were treated with anti-seizure medications for epilepsy. There were some patients who treated with various antibiotics. There were only a few patients with rheumatic diseases. And in fact, none of those patients had a systemic inflammatory disease, right? So at the moment, I'm not sure whether it's the right thing to do to apply the DRESS criteria to a systemic inflammatory disease. So if you look at this diagnostic criteria for DRESS, right? They are listed here. So it's a rash, it's fever, enlarged lymph nodes, it's involvement at least of one of the internal organs, blood count abnormalities, as well as eosinophilia and the pruritic rash. So really, many of these features are just features of systemic GI. Yes, the question. Yeah, exactly. Yes, it's a huge overlap. And in fact, I borrowed this slide from Bryce Binstad, who actually tried to apply this criteria to just patients with systemic GI. And the bottom line is that if we just apply this criteria to systemic GI, lots of patients would meet the criteria. So really, what does suggest that it may be DRESS? Really, it's this very peculiar pruritic rash that does look like a drug reaction, as well as the fact that in this patient population, we often see significant eosinophilia. So these two features do make you think about the possibility of DRESS. However, I don't know what's happening in Cleveland, but I can tell you that we started seeing more and more patients with Still's disease who develop this rash at the initial presentation of the disease. And in fact, some of these patients would start with this rash and over time would develop other features of Still's disease or systemic juvenile idiopathic arthritis. So the phenotype is changing. This particular rash was seen in the past, but in a disease onset, but it was actually very rare. But for whatever reason, it's becoming more and more frequent. It's not just here. Here, I'm actually quoting a couple of papers from Europe. One is from Spain. This paper is focused mainly on the adult onset Still's disease. The paper from France, from Pierre Cartier, included a large cohort of patients with still systemic juvenile idiopathic arthritis, pediatric patients. So both papers noted that about 15–20% of their patients have this rash at disease onset. And when they looked sort of what happened with those patients over time, many of them actually developed recurrent episodes of MAS, refractory disease, and this particular lung disease. So clearly there is this association between the presence of this rash at disease onset and a very difficult, very refractory course of the disease. And again, when we looked at these patients more in terms of biomarkers, we picked up again, this patient population was distinguished by very, very high levels of IL-18. So the point is that this pruritic rash does suggest the possibility of a drug reaction. But the point is that we see more and more patients who develop this rash well before any kind of exposure to drugs. And if you look at the histopathology of these lesions, typically we would see aggregated dyskeratosis, necrotic keratinocytes in the upper layer of epidermis. And we also would see some perivascular inflammatory infiltrate composed predominantly of neutrophils and some lymphocytes with occasional presence of eosinophils in the upper and mid-dermis. Although I don't think we have a clear distinctive histopathological picture for DRESS, but typically when I looked at the literature, in typical DRESS, we would see more often interface dermatitis or even basal vacuolization that we've never seen in our patient. To me, honestly, the histopathology of these lesions reminds very much what we might see, the neutrophilic dermatosis that we might see in various autoinflammatory diseases, including cryopyrin-associated periodic fever syndromes. The same true actually is for eosinophilia as well. Two groups, one in Harvard, the other one in Mayo Clinic, looked at the eosinophilia over time in patients with systemic JIA, and what became clear is that these days eosinophilia occurs up to 40% of the patients with systemic JIA at disease onset, and often precedes any kind of therapy. And the conclusion that from both papers is, in fact, that eosinophilic expansion in this patient population is probably driven by the inflammatory activity of SGIA rather than a drug reaction. And interestingly, if you go back to the original paper that Vivian published in 2019, so even in her sort of original cohort, there were patients exposed to the biologics and patients not exposed to the biologics. And if you look at the prevalence of the this sort of very pruritic non-evanescent rash, it's actually not very different between the groups. And the same true for peripheral eosinophilia. So the bottom line is that although the presence of these two features do point to the possibility of I don't know what happened, to the possibility of a drug reaction. However, there are lots of arguments that do not support this hypothesis. But by the way, one thing I wanted to mention that even if it is DRESS, now I think there is more and more literature suggestive that a DRESS is driven by interferon gamma. So I guess there is still the possibility of an overlap between those two phenomena. Another very relevant clinical observation is that there are striking geographic differences in the prevalence of this complication that do not correlate with the patterns of utilization of the biologics. Just before COVID, I was in China, personally examined quite a few patients with exactly this phenotype. Those patients had never been exposed to the biologics. And just actually last month, there were 3 papers coming from China, India, as well as Malaysia, describing pretty large cohorts of patients with exactly this phenotype, with systemic GI, exactly this lung disease, no biologic problem. So that certainly is interesting. And the other interesting observation is that in Europe, the biologics were introduced exactly at the same time as they were here in 2012. And the patterns of utilization of difference, they use a bit more steroids at the disease onset. And interestingly, until recently, this complication was exceptionally rare in Europe, but they started seeing more and more patients with this phenotype over the last 2 years. So there was a delay in the sort of the emergence of this complication compared to us. And there is a group of physicians in Rome, actually, they're in Rome right now, who are interested in this, and they kind of looked at the cohort of patients with this complication. And again, in that cohort, not all of the patients had been exposed to the biologics. 6 of the 34 patients they described in a recent publication had never seen biologics. So another interesting feature is that this lung disease appears to be very specific to systemic juvenile idiopathic arthritis. Actemra is used for poly-JIA, for rheumatoid arthritis. You know, it's a very popular drug in many other rheumatic diseases. IL-1 inhibiting agents are used a lot for various autoinflammatory conditions. And we don't see this complication in those diseases. It's very specific to systemic juvenile idiopathic arthritis. So that suggests that it must be something specific to this disease that drives this complication and that drives this pruritic rash. And the question is whether it could be IL-18. I've been, mentioning IL-18 quite a bit. And interestingly, there are several groups, mainly in Japan, who actually are developing this concept of IL-18-induced innate type allergic inflammation. So it started with a very interesting paper. This Japanese group produced mice that was transgenic for caspase-1 in the keratinocytes, right? So caspase-1 typically activates IL-18 and IL-1 beta as well. So these mice were activating IL-18 and IL-1 in their keratinocytes. And interestingly, they developed a very peculiar pruritic rash. And the histopathology of this rash actually is very similar to what we see in our patients. So the question is, are we dealing with this sort of IL-18 driven innate allergy, where in fact you don't need an antigen to trigger an allergic reaction? Just stimulation of mast cells and basophils with IL-18 in conjunction with IL-33 may drive this sort of reaction that may look very much like classic allergy. So the question is, are we dealing with this phenomenon in this patient population? Now, I would like to go back to this idea that there are striking geographic differences in the prevalence of this complication. That certainly points to the environmental factor. So the question is, what exactly it might be? And so one possible explanation is it possible that we are dealing with some kind of infection that is favored by IL-1 and IL-6 inhibition? So far, we have not been able to identify this infection. So another possibility is it possible that we are dealing with some kind of an emerging environmental factor? You all are familiar with MIS-C, right? We did not see this disease before COVID, and then suddenly, boom, we have this complication. So is it possible that there is another environmental factor that somehow induces this complication in genetically susceptible individuals? And when I say genetically susceptible individuals, I'm referring to the presence of this HLA-DRB1 1501 allele. So that's another hypothesis that is gaining popularity in our field. I think I'm running out of time, so I'll skip over the T-cell plasticity hypothesis and just kind of to summarize this part of my talk. So again, going back to this question, do IL-1 and IL-6 inhibiting agent contribute to the development of this complication? Certainly, in favor of this idea, there is the fact that the emergence of this complication, at least in the North America, did coincide with the introduction of these drugs. Most of these patients did receive these drugs. Many patients have some kind of a history of drug intolerance, and many of these patients do develop pruritic rash and eosinophilia, and some patients actually do get better when the drugs are stopped. However, what's not in favor of this hypothesis is those geographic differences that we just discussed. Lots of patients who develop these complications had never been exposed to the biologics. And in fact, based on our experience and the experience at Harvard and in Rome, in Italy, many of these patients, in fact, improve over time despite staying on this drug. So the bottom line is that although the group at Stanford still insists on this hypothesis, we don't agree with that, and we think it's something about the disease itself rather than the reaction to the drugs. So based on this consideration, very briefly, I would like to touch on the management of this complication. So again, if you agree with the group at Stanford, in accordance with the DRESS hypothesis, expeditious withdrawal of IL-1 and IL-6 inhibition and careful consideration of treatment recommendations for DRESS are absolutely necessary. And that recommendation that they came up with is based on a recent study that they just published. It's still not in press, but it's available online. They actually created a convenience cohort of patients in whom they stopped biologics, and they also had patients who continued the treatment. And they actually found quite impressive differences in the outcome between those who stopped the treatment and those who continued the treatment. And again, they strongly feel that based on that observation, we need to follow the DRESS rules when we diagnose this particular lung complication. In contrast, in other centers, including us, we don't see that. We don't think that stopping the biologics help. In fact, very often when we stop biologics, the disease gets out of control. These patients develop macrophage activation syndrome, and it worsens actually the lung disease even more. And we certainly have seen many patients in our center who improved, whose lung disease improved despite the fact that we continued the treatment with the biologics. So at the moment, well, we'll get to that in a moment, but I would like to return back to the idea of a very strong association with HLA-DRB115 alleles. The association is strong, and actually, what I did here, I looked at several recent publications that looked at the presence of this allele in the patients with the lung disease, and those are my numbers based kind of on a simple meta-analysis, right? So if you look at all those papers, again, this allele is present in about 25% of the healthy population. It's present in about 25% of patients with systemic JIA without the lung disease, and it's present in about 80% of patients with the lung disease. So that raises several questions. First of all, do we need to perform HLA typing at the time of the disease of SJIA diagnosis? How do we manage biologics in those patients who carry this particular risk haplotype? In accordance to the DRESS hypothesis, we should not use them and look for alternative treatments. At the moment, we don't have those. JAK inhibitors probably are helpful in some of the patients, but I'm actually a bit disappointed, although there are two large phase 3 clinical trials of JAK inhibitors in systemic JIA that are still in progress, so we'll have those results. But I would like also to give you some numbers, right? So actually, this slide was generated by the mother of one of my patients with this lung disease. So I don't know how she managed to get a full access to this Komodo Health Prism database, which covers claims on approximately 330 million people in the United States. And what she did there with that, she applied the ICD codes for SJIA, MAS, HLH, high-resolution chest CT, interstitial lung disease to that database. And that's the numbers that she came up with. And to me, the numbers look about right. So if you look at, she believes that the total number of patients with newly diagnosed systemic JIA between 2021 and 2015 was about 11,000. And based on my knowledge of SJIA epidemiology, I think the number is about right. I think she's capturing most of the patients. And in that cohort, 254 patients developed this lung disease. So that suggests that the risk factor is about 2%. And if you do the math, and if you sort of consider the fact that this HLA-DR allele is present in 25% of all patients with systemic JIA and 80% of the patients with the lung disease, the presence of this particular allele increases the risk to develop this lung disease to 7, maybe 8%, right? So it's a substantial risk, but still it's a relatively low risk. So if we go back to this number, 11,000, right? A quarter of these patients, which is about 3,000 patients, will be HLA carriers of this particular risk allele. And only a tiny proportion of them will develop the lung disease, right? If we follow this, the recommendations of the group from Stanford, right? We will deprive thousands of patients with this disease of a very, very effective treatment. So for that reason, and briefly, I have time. Yes, I do have a few minutes. So I would like to mention another interesting study, which is a study that is coming from a very interesting Dutch center in Utrecht. And it's a place where the patient shows up in your clinic, diagnosed with systemic JIA, and on that very day, they start anakinra. So pretty much all the patients, without exception, in their center are started on anakinra right away. So they published this paper just a few months ago. The study included 65 consecutive patients. As expected, 26% of them carried this particular HLA risk allele. And in this particular paper, the follow-up was about 8 years, mean follow-up. Only one patient developed the lung disease, and this patient actually did carry the risk haplotype. And interestingly, they did not see other differences in the overall outcome or even prevalence of the drug reaction based on when they stratified the patients based on the presence of the risk haplotype. In fact, of the 3 patients who did develop serious adverse reactions to biologics, in fact, only one was a carrier. So based on that, we think our approach is that certainly we need to think about the possibility of adverse reaction here. But not based on our experience, we believe that a poorly controlled underlying systemic JIA is a much more serious risk factor for this complication. So if the biologics provide good control of the underlying disease, we don't stop them, we continue. But we typically add something that would target T cells or interferon gamma signaling based on the observations that I provided earlier. And certainly in our field, I would say JAK inhibitors specifically for this indication are becoming more and more popular. Plus, we certainly need to think, remember pulmonary proteinosis, right? This proteinaceous material, it's kind of it's a good feeding media for bacteria. So we need to worry about PJP. Certainly we need a very aggressive prophylaxis for various infections in that patient population. So I still have a few minutes, right? So that's actually our kind of algorithm for the management of the lung disease. So first of all, when we diagnose a new patient with systemic JIA, we typically assess the baseline levels of IL-18 as well as CXCL9. We do perform an HLA DR typing specifically for the risk alleles. And then we assess the risk factors. And the risk factors, again, are listed here. That includes age of onset before the second birthday, predominantly systemic features with very little arthritis, recurrent or smoldering MAS, reactions to biologics, peripheral eosinophilia, pruritary crash, and highly increased levels of IL-18. And if at least 3 risk factors are present, we typically try to involve our pulmonary colleagues as early as possible. And we start with some kind of a sort of a baseline evaluation that we could use as a reference point in the future. What we do here would certainly very much depend on the age. Remember, I mentioned that most of these kids develop this disease very early in life. So most of these kids are not capable of doing pulmonary function testing. So what we do like in this patient population is continuous overnight pulse oximetry that provides us with information on oxygen saturation during the night, how many episodes of desaturation they had, for how long they stayed. So, it gives us numbers that could be used as a baseline for future comparison. In older kids, we actually do like the 7-minute walk test and certain PFTs with DLCO in those patients who can cooperate. And if concerning findings are present or trends, then we certainly proceed with a high-resolution chest CT. We actually surveyed our patient population through the SJA Foundation. And it's interesting that the families were very much in favor of early high-resolution chest CT screening, despite the knowledge of the fact that, it's radiation, but still the families were very much in favor of more aggressive earlier screening with high resolution chest CT. If the findings are typical, then we don't do a biopsy anymore. If there are some atypical findings on the high resolution chest CT, and by the way, those most typical features are listed on the right side of the slide. So if we don't, like just actually yesterday, I got a phone call from Medical College of Wisconsin. The looks like it's this particular complication, but patient has some bizarre nodular lesions that don't fit in this pattern, right? So in a patient like that, we would still do a biopsy. But if the findings are relatively classic, then we just proceed with the next step. And again, as I discussed earlier, we continue biologics if they are effective for the control of the underlying systemic juvenile arthritis. We add synthetic DMARDs targeting mainly T cells, including MMF, JAK inhibitors, or if you talk to people at Harvard, they're kind of becoming more and more fans of mTOR inhibitors in this patient population. Huey recently published a paper in JCI identifying upregulating mTOR signaling in that patient population. We certainly consider corticosteroids. I mean, certainly the introduction of the biologics and early initiation of biologics helped us reduce the exposure to corticosteroids in this patient population dramatically, which is good. But we are wondering whether that might be actually one of the factors why we're seeing this lung disease more frequently. So we certainly do consider corticosteroids in some of these patients. We stop corticosteroids if they are marginally effective for the control of the underlying disease. And then, as I mentioned, aggressive PJP prophylaxis is very, very critical here. Those patients who died with this phenotype, most of them actually died with PJP. And we also use azithromycin. And the reason for that, I think my pulmonary colleagues are saying, is that in addition to antibacterial prophylaxis, azithromycin does have some anti-inflammatory properties in the lungs, and that's the reason we like this as well. And then, I can show you the outcomes. Again, I don't have time, but the point of, lots of patients are improving with this disease, but lots of patients do not. And in fact, now we have a very good experience with quite a few patients who ended up getting a hematopoietic stem cell transplantation. And to me, it was striking how much and how quickly their lung disease improved after DMT. This, again, that's our local Cincinnati recommendations. But if you look at this particular publication, which is again not in print yet, but it's the Europeans recognize the fact that we have adult onset Still's disease and systemic JI. We all agree that it's the same disease, but if you look at the existing recommendations for the management, they're very different. So the Europeans recognize that it should be reconciled. So there was this big effort to come up with sort of a unified approach to the management of both SJI and adult onset Still's disease in the same manner. And a good chunk of this paper actually is devoted to the management of the lung disease. And I can tell you that what's there is very consistent with the algorithm that I just described. So just to let you know that I mentioned this 67% mortality at the beginning of my talk. Certainly we are very far. That's the Cincinnati experience. So we lost a few patients, but it's not 67%. But certainly many of them do require some oxygen supplementation over time. And these are my conclusions, and I think I'm totally out of time. Well, thank you for your attention.
Thank you for that fascinating talk. That was just really an amazing history of how you've gone through and come up with these conclusions. It's really, really something that, as an ID person, I always think, gosh, those allergists and rheumatologists are so smart. They're, I'm looking at the bacteria. They're looking at everything much smaller. Are there any questions? Oh, and before I forget, because I will forget, there is a meet and greet with our visiting professor in the community room right after we're done with a couple questions.
Thank you. Great talk. It's fun. So a quick question. I'm going to discuss this patient with you in detail, but so that others can also think about it. I have a recently diagnosed SJIA, 14-month-old, mostly systemic symptoms, flaring on increasing doses of anakinra. We just got the IL-18 levels yesterday. It was 533,000. We got a CT chest that was normal. No pulmonary symptoms. CT seems to be normal. How often would you repeat CT chest in this patient with such a high risk factor? The
So-
age and
yeah,
IL-18.
So again, sort of, we can discuss it, but really, we in this patient population, we kind of focus on more on a functional assessment, like overnight pulse oximetry. Again, if they can cooperate with a 7-minute walk test, I think it's
This
so.
14-month-old.
Oh yeah, 14 months. So sorry. Yeah, yeah. So overnight pulse oximetry, but I probably would not rush with high resolution chest CT. I would not do it on an annual basis just for the sake of monitoring. I would look for functional clues initially.
Thank you. We'll discuss more.
Thank you for this wonderful talk. I just have a question. You said that if the underlying disease is well controlled with the IL-6 or the IL-1 inhibitors, you would keep them on the same biologics and just add treatment. What is usually the timeline that you expect these patients to improve, for example, to say whether, oh, this is working or this is not working for them?
It's not happening overnight. You saw the histopathology,
Yeah.
you saw the even some fibrosis. Although I have to say that the picture that I showed you, right?
Mhm.
So my pathologist is telling me when you do this pentachrome stain, right? You look at the color, and if it's brownish, it's a sort of a very mature fibrosis that is irreversible. When it's kind of greenish, bluish, then it's sort of still maybe. But anyway, the point is that it's not something that is going to resolve over time. So in my experience, it takes at least 6 months. So really, if we're very worried, we would not repeat a high resolution chest CT before the 6-month time point.
Would you ever consider changing the biologics, like taking the patient off the IL-1 or the IL-6 if you think their underlying disease is not well controlled? I know that you.
Yeah, exactly. That's what I said. That if we believe that the effect is marginal for the
Mhm.
control on the underlying disease, then we do stop. I mean, what's the point?
But
Right?
would you switch to something else? Because we know these are the most.
Well, there is not
effective.
much to work with, right? So we have we have a few IL-6 inhibiting biologics. Certainly, we have a few IL-1 inhibiting biologics. There is one drug that is coming that potentially could be interesting, right? It's called, it doesn't have a name yet. It's called MAS-A25. It's a bispecific monoclonal antibody that blocks both IL-1 beta and IL-18 at the same time, right? It's available only on the compassionate base uses, but I know lots of patients in the country who own this. But otherwise, no, not really. Switching biologics usually does not help that much, right? We are looking for something else. And again, if you look at what's happening in the country, JAK inhibitors are becoming more and more popular for this group. And for some reason, I don't know why, but people like ruxolitinib more than anything else. And I think it's based on the experience with interferonopathies, with SAVI in particular. Because remember, Rafael Golubachmansky specifically looked at the ability of various JAK inhibitors to bring upregulated interferon, type 1 interferon signaling in those patients, and she incubated cells with various JAK inhibitors, and Ruxa looked the best. That's how they ended up using Ruxa. So I think because of that, Ruxa is becoming more and more popular drug. And the other advantage is that until recently, Ruxa was the only JAK inhibitor available in a liquid preparation. So you can dose it properly for a little kid like, your patient who's 14 months old. Yeah. Yes, yes. So there are several trials right now. So there was one trial in adult onset Still's disease, and it was a sort of a small phase 2 trial. They used a drug called recombinant IL-18 binding protein, which is, I'm not sure whether it's the best strategy to block IL-18 activity, but the trial, it did produce positive results, okay, but they were not terribly impressive. So there are a few drugs in pipeline. There are several actually companies that produce anti-IL-18 agents. Probably the most known clinical trial is it's MASA25. It's bispecific monoclonal antibody. The current trial enrolls patients with genetic inflammatories, including an LC4 gain of function mutation, as well as patients with XLP. But the trial looks like it's going to be expanded specifically to include patients with refractory systemic. And there are lots of publications on just small series, passionate use. But yeah, there are quite a few companies that are targeting IL-18. We'll see. I don't know. Honestly, if you ask me what I think, I still don't know.
Yeah, just the idea that it will be brand, right?
Yeah, no. Mhm.
Thank you so much. Didn't your pulmonary colleague find anything on the bucket of the differences in the public
Really, nothing now. We've done it quite a bit actually, Grant Schuler, one of my colleagues, actually is doing single cell RNA-seq on the cells from bronchoalveolar lavage, but nothing particularly distinctive, really. We still do it. The question that I often get is in pulmonary alveolar proteinosis, right? You would do bronchoalveolar lavage to remove that proteinaceous material and improve oxygenation. It doesn't work that well in this patient population, right? Because again, remember I was showing those pictures. If you look at the interstitium, right, in patients with PAB, the interstitium looks pretty good. And if you remove this proteinaceous material here, correct, you improve oxygenation dramatically, but that's not what we have in our patient. We have this inflammatory activity. So even if you do lavage and remove this proteinaceous stuff, it's not going to help with oxygenation stuff.